Good morning, everyone. First of all, I would like to thank Scientific Committee AIOS for giving me an opportunity, and also Dr. Manish Nagpal for having given me the opportunity to speak first. So I'm here today to speak on the pneumatic retinopexy, the extended criteria. That's a prospective comparison of the clinical trial group inclusion criteria and the extended criteria. So as we all know, there are two surgical repair options available. The one is the operating room based, and the another one is the office based, which is more quicker in access and involving less cost, that is pneumatic retinopexy. So the conclusions of the multi-centered pneumatic retinopexy clinical trial, which compared between the pneumatic retinopexy and scleral buckle, showed better results for the pneumatic retinopexy with better visual acuity of macula off RRDs and equivalent visual acuity for macula on detachments, less anisometropia, less morbidity, less cataract development, and finally the same anatomical reattachment rates. So the optimal management of the primary rhegmatogenous retinal detachment is still a subject of controversy. Pneumatic retinopexy has best been studied under the clinical trial guidelines. So some of the inclusion criteria of the CTG are a single tear, which are not larger than 30 degrees, that is 1 clock hour, or a group of small tears or holes within 1 clock hour. And of course, all the breaks has to be above 4 and 8 o'clock meridian. So the purpose of our study was to evaluate and compare the success of pneumatic retinopexy for the retinal detachments that meet the clinical trial group inclusion criteria to those with the extended criteria. In simple words, to compare the pathology limited to 30 degrees, that is 1 clock hour, to pathology greater than 1 clock hour. So there is no clear guidelines between what can and should be treated with pneumatic retinopexy versus buccal or vitrectomy. So coming to some of I'll give you a glimpse of the inclusion criteria of the extended criteria. Includes the multiple breaks spanning greater than 30 degrees. In these cases, we used to alternate the head positions for the patients after the gas injection every 4 to 5 hours. Additional retinal breaks in the attached retina were prior treated with a triple barrier laser photocoagulation prior to the gas injection. The patients with inferior RDs were also included, and of course the patient had to do a little bit of acrobatics, that is hyperextension of the neck. Extensive lattice degeneration of more than 3 hours were again treated with triple barrier laser photocoagulation before the gas injection. Patients with concurrent macular hole RDs were also included, and no change in the PR positioning was advised for those patients. Large break greater than 30 degrees, even patients with PVR of grade C1 and C2 were also included. So it was a prospective multi-center REB approved study, mainly done in Toronto, and some of the patients were taken from Canton, Ohio. So there were 2 sessions available. The one was doing a cryotherapy before and doing the gas at the same sitting, were done in the patients in which there were small or hard to find breaks, media opacity is preventing the laser, and pigment atrophy preventing adequate laser burn. And in 2 sessions, that is inject gas first, reattach the retina, and then do the laser or cryotherapy in day 1 or day 2, were done in most of the patients who had large or extensive breaks, bullous detachment, tear over the scleral buckle, recently operated eye, and very posterior breaks. So management of intraocular pressure is very important, because if we don't put the gas before, that is, if we need to do a gas injection, and then if we try to tap the AC, there is always a risk of migration of the gas into the anterior chamber. So it's always better to do an AC paracentesis first and then do the gas injection. Always aim for a big gas bubble, that is final volume of 1.2. As we all know, the inject C3F8 or SF6, 0.6 ml of SF6, which doubles in volume, making it a volume of 1.2, or the C3F8, which quadruples, making it as 1.2. So the aim is a single large bubble, ensure that the gas bubble is in the vitreous and the CRA is wide open and non-pulsatile. So after taking all aseptic precautions, the gas is injected supratemporally and direct the needle to the center of the vitreous. So the most important thing here is the steam rolling maneuver, that is, uses the buoyancy force of the bubble. It prevents the iatrogenic macular detachment and inferior migration of subretinal fluid. So we ask the patient to do face down immediately after the bubble injection, and then head is slowly lifted over 10 to 15 minutes. So the study was called a success if the retina was attached with the pneumatic retinopexy alone, adjunctive with laser, gas, or cryo, but failure if the patient needed a second operation, either the buccal or vitrectomy. So We divided into two groups, that is phakic and pseudophakic. Of the total, 67% were phakic and 32% were pseudophakic. And if you see in the phakic, 80% of the patients were successful with the PR alone who fit into the CTG inclusion criteria, and 73% were successful in extended criteria. So if you take the 6-month visual acuity, the CTG showed around 73.3% success compared to the extended, which is quite closer at 65.5%. And if you take the 6-month visual acuity in macula off group, extended did really well with 100% of success rate as compared to the CTG inclusion criteria of 89%. So the results in the pseudophakic were 61% were successful in CTG, those who fit into the CTG criteria, and 50% were successful in the extended criteria. And if you see the 6-month visual acuity result, CTG did a 72.7% success rate as compared to the extended of 64.3%. And in case of macula off group, CTG did 78%, 50% in extended criteria, not very far behind. So what were the reasons for the pneumatic failure? Either the new brakes or the missed brakes, persistent open brakes, or PVR. So all patients who had failure had to undergo a pars plana vitrectomy, either with the scleral buckle or with the oil, but 100% of both the groups had anatomical reattachment following surgical intervention. So if you see the complications here in this table, see a little bit of higher trend of ERM formation in the extended group as compared to the CTG. So with the extended criteria, up to 70% of all rhegmatogenous retinal detachments may be the candidates for pneumatic retinopexy. So the phakic extended criteria was 73.3% initial success rate versus the CTG, which showed around 80.4%. If you see the visual acuity of better than 20/50, it was 65% compared to 73%. So the differences were not really statistically significant. And if you see the pseudophakic extended criteria of 50% initial success versus the CTG of 61%, the differences again were not very statistically significant. So to conclude, extended criteria can apply to 25% more phakic retinal detachments and 38% more pseudophakic detachments. There was around 70% of overall success rate with pneumatic retinopexy alone, adjunctive with the laser, cryo, or the gas. 100% of the both groups had anatomical reattachment following pars plana vitrectomy. As I said earlier, the rate of complications were similar, but little bit a higher trend of ERM formation in extended group. And PPV may not be an optimal choice of secondary intervention for phakics due to the cataract formation and prolonged recovery time. I thank my mentors, Dr. Devini, Dr. Lam, and Dr. Curtis, who allowed me to do a wonderful study. And also I call Dr. Guru Prasad as Dr. Guru, who has always been a good support to me. Thank you very much.